Module 6 is covering two chapters, chapter 21 and 22, and it is about dermatological disorders and also communicable diseases. So the first part of this module is about immunizations. So just general info that we need to know about giving immunizations, which you probably learned most of this before. Um, Things that we can educate either the patient or the parents about the immunizations. So letting them know that some immunizations may cause mild fever, soreness, and redness at the injection site. Parents can give acetaminophen after the immunization if they wish, if they do have pain that persists. So we can teach them the appropriate doses of acetaminophen to give. If they have a fever before the immunization, so if they're already sick, we want to delay the immunization till later on when they are fever-free. If they do have very mild cold symptoms like a runny nose or sneezing or anything like that, in general, it is okay to go ahead and give the vaccine. But if they are so ill that they have a fever, then we need to hold on until they are fever-free. They, of course, need to sign the consent. So in our case, it's going to be a parent signing the consent. And given the vaccine information statement, which I'm sure we've all seen what that is, that lists all of the side effects and things that the patient or the caregiver needs to know. Depending on what your electronic health record looks like, if you have one, we're generally going to be documenting things like the lot number on the vaccine. So either on the vial or on the prefilled syringe, there's going to be a lot number, an expiration date, of course, the manufacturer, and we're going to be charting the date that we gave the immunization and the site that we gave it in case there's any sort of adverse reaction that we need to go back and look at, what arm or leg did we give this immunization in. If there is a severe adverse effect, one that we don't expect, like the redness, soreness, mild fever, mild flu-like symptoms that people can feel after they have certain immunizations, but anything that's unexpected, like does the patient have a seizure or something like that, we need to report those types of adverse effects to the CDC. For older children, we can, of course, give most vaccines in their deltoid, and we can ask them which arm they want their vaccine in. For infants, we are usually going to be giving it in the upper vastus lateralis, which is sort of like the quadricep area, but it's more of on the side of the leg, sort of top side, if that makes sense. It's sort of hard to describe when I'm recording myself. But if you want to look up where that muscle is, if you can't remember, it is in the thigh area. When we're giving the vaccine, so we can have parents help us hold. So for a baby, you probably won't need help holding unless it's an older baby, possibly. But for especially like toddlers or young school-age children, they're usually fairly scared to get vaccines if they are old enough to know what's going on. So we can have parents help hold them, sort of like holding them down, which some parents don't necessarily always love. But sometimes even just putting the child sort of on their lap and giving them almost sort of a hug around their arms to sort of hold them down to try to make sure that they're not thrashing around while we're giving them their injection. We can, of course, use things like distraction, like iPads, or if parents have their phone and they want to play a video, whatever we can do to distract them while they're getting the vaccine. We could give them a reward after, so things like stickers or candy or whatever the parents are okay with. So this is a chart of the recommended immunizations for children. You do not need to memorize this chart by any means. Its purpose is to sort of allow you to see when children are getting these different vaccines and how many doses they get, we'll go over some of the vaccines specifically. But we don't need to memorize exactly when each immunization is given. Perhaps if you worked at a pediatrician's office, you may have this memorized, but most people don't. We just refer to these charts or other sort of publications that tell us when certain vaccines are given. What you guys need to know is more generalities about the vaccines, which we'll talk about on the forthcoming slides. So one specific immunization that we're going to talk about is the hepatitis B vaccine. It is given in 3 doses. So the first dose is administered to all newborns, unless of course the parents refuse it. And then they get 2 other doses around 1 to 2 months of age and then around 9 to 12 months of age. If the mother is positive for hepatitis B, we do still give the hepatitis B vaccine, and we also give hepatitis B immune globulin, which is the HBIG on your screen. So the immune globulin helps to prevent infection when someone is exposed to a certain disease. If a dose is missed, the series doesn't have to be restarted. It can just be continued. There is one specific contraindication. It's a hypersensitivity to yeast. Hepatitis A is another hepatitis vaccine. Hepatitis A is highly contagious and can be spread through food and water, as well as sex and drug use as well. But it's important for travel because some areas, especially international travel, some areas have a lot of cases of hepatitis A, so it may be more likely that someone could catch it in that area. So this is given to all children 12 months and older, but not before that age. 2 doses are given at least 6 to 18 months apart. So the next vaccine is the DTaP vaccine. So this stands for diphtheria, tetanus, and pertussis. So diphtheria, if you don't know what that is, it is a respiratory illness that can cause things like sore throat, runny nose, and difficulty breathing. We don't really see it that much anymore because of this vaccine. This one, there's 4 doses as an infant and toddler, so at 2, 4, and 6 months, and then 15 to 18 months. And then there's one final 5th dose between 4 to 6 years of age, usually before starting kindergarten. This one is sometimes seen as one of the painful ones, so can cause a lot of soreness and tenderness at the injection site. Also, just general sort of not feeling very well, like loss of appetite and irritability. Seizures were a rare side effect because of the pertussis component. Vaccine is manufactured differently now, and apparently that's much, much rarer. But if parents do not want that pertussis component, there is a just DT vaccine, so the diphtheria and tetanus portions only that they can choose to have instead. I've personally never seen that one. And then we have the Hib vaccine, or Haemophilus influenza type B. So this is, even though it has the word influenza in it, it is a bacteria. So this bacteria can cause several different illnesses, the most severe being meningitis, but it can also cause things like conjunctivitis, otitis media, and sinusitis. This one's given at 2, 4, 6, and then 12 to 15 months. The next immunization is pneumococcal, called PCV13. The brand name is Prevnar 13. There's also PPSV 23. So PCV13 is recommended for kids that are younger than 5, and it protects against Streptococcus pneumoniae, sometimes just called pneumococcus. So this bacteria can cause a wide range of infections, but In children, most commonly meningitis and ear infections. There are 4 doses of this at 2, 4, 6, and then 12 to 15 months. The PBSV23 is usually reserved for older children and adults. The next one is the rotavirus vaccine. So rotavirus is a GI illness that causes very severe diarrhea and dehydration. This vaccine is a live vaccine, so we do need to use caution if the patient is immunocompromised. A live vaccine basically means that it contains a small amount of the weakened virus. There are 2 different brands of this, so the schedules vary based on the brand. The unique thing about this immunization is that it is an oral liquid. So we just administer it as we would any other oral liquid medication. It's also contraindicated with other GI illnesses that we will talk about later, such as intussusception and other certain GI disorders. The inactivated poliovirus immunization is for polio. So the newer version of this is inactivated. The older version was a live oral vaccine in the United States. That one had some more side effects and contraindications. So now it's inactivated, so it's safer, and we can give it to children who are immunocompromised in most instances. It is given in a series of 4 doses at 2, 4, 6 to 18 months, and then 4 to 6 years. We're all probably familiar with the influenza vaccine, but for children, they can start receiving it once they're 6 months of age. Their first dose, if they're 8 or younger, they need to have 2 doses. So sort of like their first dose and then an immediate booster that is given at least 4 weeks apart. If they're over 2, they can receive the nasal spray immunization for influenza if it's available. However, studies have shown that it's possibly less effective than the IM injection. The nasal spray is contraindicated with respiratory problems such as asthma, and it can cause mild flu-like symptoms because it is a live vaccine. With both the nasal spray and the injection, we need to use caution in those that are allergic to eggs or egg products. The MMR vaccine, which protects against measles, mumps, and rubella, and the varicella vaccine, which protects against varicella or chickenpox. These 2 are similar because they are both live vaccines. They are both given subcutaneously instead of intramuscularly. For both of them, they need a minimum age of 12 months for the first dose, and the second dose is usually given at age 4 to 6 years. They're both contraindicated in severely immunocompromised patients or pregnant patients. For the MMR vaccine, some side effects that are common are things like a rash, a fever, swollen cheeks, and mild joint pain. For the varicella vaccine, a possible side effect is that the client can experience a vesicular varicella-like rash at the injection site. And it should also not be administered if any antiviral drugs have been given in the previous 24 hours. The meningococcal vaccine protects against meningitis. This first one is usually given between ages 11 to 12 years, within a booster at 16 years of age. This one is also given sub-Q. Then we have the meningococcal serogroup B vaccine. So this is the one that's typically given to students who are about to enter college and maybe are going to be living in a dorm. It can also be given to others who are at higher risk for various reasons. But this one's usually given between ages 10 to 25. There are 2 different brands in the US and they're not interchangeable. So if you start out with one, then you have to finish with the other. Then we have the Tdap which is for tetanus, diphtheria, and pertussis. This is the one that is for older children and adults, so similar to the DTaP. But this one's given to ages 11 to 12 years old. It's also recommended to be given to pregnant women somewhere around usually 27 to 36 weeks gestation. The primary reason for that is to prevent pertussis to be transmitted to the infant after it's born. And then we have the HPV, human papillomavirus vaccine. One of the brand names is Gardasil. So HPV is one of the most common causes of genital warts. So this vaccine can help prevent cervical, anal, oral, and penile cancers. It's typically given around ages 11 to 12 years of age in a 2-dose series. One of the very common side effects with this one is syncope. So now we're going to start talking about some of the actual communicable diseases. So if we are assessing a child who we think may be experiencing a communicable disease, things that we are going to ask them or their caregiver about and assess, do a physical assessment. So we're going to ask them about exposure. So has the child been around other children who have this specific disease? Are they in close contact with other children? Like, do they go to daycare? Have family members had been exposed or had any of these communicable diseases? Things like that. Consider the incubation period. So if they were exposed, some of these that we're going to talk about, there's certain incubation period times that you can look at. So like, for example, if a child was exposed 3 weeks ago and they're just now showing symptoms, is it from what they were exposed to, or is this something different? Like, has it been too long? Has the child had any communicable diseases in the past? Are they up to date on their immunizations? Do they need any now, according to the recommended schedule? Any child that we may come in contact to that's 2 months or younger and they have a fever, generally over 101 degrees Fahrenheit, should be seen by a healthcare professional in some way, shape, or form. So at the very least, going to their pediatrician. If they're, depending on what their symptoms are, of course, do they need to go to like an urgent care or an emergency room? So very young infants do not have very good immune systems, and it can progress to sepsis or being very bad very quickly. So if it's a very, very young baby, less than 2 months, they need to be seen. However, some of these diseases that we're going to be talking about don't always need to be seen by a provider, so they can be taken care of at home. Physical examination wise, certain signs that we could see in the child could be things like runny nose, cough, do they have a fever, do they just generally feel sort of bad? They could also have things like changes in their behavior. So do they not want to play anymore? Are they lethargic? Do they not want to eat? Are they especially irritable? Do they have a rash? Are their lymph nodes enlarged? Of course, do they have a fever? Are they nauseous? Are they vomiting, or do they have diarrhea? And are they in any pain? There's also a little portion on here about skin assessment, because the end of this module does talk about dermatological disorders. So this is sort of a little bit different than what I was just talking about. But for skin assessment, as you guys all know, if somebody is hospitalized, and even a child, we usually want to be turning them every 2 hours and assessing their skin. So even if it's just taking a very quick look at their skin, that's not overtly visible when they are laying down. So do they have any lesions, any breakdown, any redness, or anything that would cause concern? If they have a pulse ox on, we want to change the location of that every 2 to 6 hours. Well, it's sort of a wide range, but it sort of depends on the child's age and what sort of pulse ox you're using. So a lot of times with children, we're using the ones that are sort of like stickers, which can cause like pressure ulcers or skin breakdown a little bit more easily because of that stickiness that's in there. So we want to be rotating that every so often so that there's no skin breakdown. If the patient is incontinent, so either if they are a baby and they're not potty trained yet, or if they're so ill that they are now incontinent, we want to be applying some sort of barrier cream, which for children is usually just sort of like normal diaper cream, like zinc or Aquaphor or Desitin, any of those sorts of things. We want to avoid vigorous scrubbing on their bottom so that we're, again, not causing any sort of skin breakdown. And we want to change their diaper and linen if it gets wet promptly. Again, so we don't have any sort of skin breakdown in the diaper area from either stool or urine. We want to pad bony prominences if we need to, so just like we do with adults, if there's any bony prominences that we're worried about getting a pressure ulcer in. There's also a Braden scale that can be used for children. Sometimes it's modified just a little bit because of children are obviously different than adults. But again, that's something that's usually filled out at least once a shift every single day. So something that's like required for you to chart. Erythema infectiosum, or Fifth's disease. So this disease is commonly referred to as fifth disease because historically it was the fifth most common red rash in children. So for whatever reason, that name stuck. This disease commonly affects kids that are about ages 5 to 15 years old, so school-age children. This rash is caused by a virus called human parvovirus B19. It's a self-limiting viral infection, but it can have this persistent lacy rash for several weeks after initial infection. So it's transmitted by respiratory secretions. So if there was a child admitted with this, they would be on droplet precautions. The child is considered contagious until this lacy red rash appears. Other symptoms are things like fever, upper respiratory symptoms, headache. The other hallmark of this disease is a slapped cheeks rash appearance. So their cheeks are usually bright red, and then they have this lacy rash on other areas of the body. Like I said, this one's usually self-limiting, so usually you're not going to see a child admitted with this. It could be they are admitted with something else and just happen to have this. But usually this is just taken care of at home with acetaminophen or ibuprofen for fever, or if they have any discomfort from the fever, and making sure that they are staying adequately hydrated. Hand, foot, and mouth disease is another communicable disease that is caused by a virus. So it's caused by the Coxsackie virus or enterovirus. This one's also self-limiting, meaning that it's usually taken care of at home. The children may be seen in the pediatrician's office, but they're usually not admitted for this specifically. It's common in infants and children less than 10 years old, although recently I have heard of different junior highs and high schools actually having outbreaks of this. And adults can get it as well, especially parents of children who have hand, foot, and mouth disease. It's spread by direct contact, fecal oral contact, and droplet. So a lot of education on hand washing and cleaning surfaces if a child does have this. The virus may be shed for several weeks, meaning that the patient is basically contagious for a longer period of time. Besides this rash that we're going to talk about in a second, the patient can have cold symptoms, runny nose, sore throat, and fever. But then the rash is a small vesicular rash that's usually on the hands, on the feet. It can be around the mouth, on the butt, and the genitalia. So the main problem with this one is that if it's around the mouth, Um, the child can not want to eat and drink, so they could become dehydrated. So the rash isn't very comfortable. It can be very painful. So the child may not want to eat or drink if the rash is around the mouth or even in the mouth. So that could be one reason why they are possibly admitted. But again, usually this is just taken care of at home. Again, with trying to keep the child hydrated, giving acetaminophen or ibuprofen for pain and fever, um, over-the-counter sprays, anesthetic mouth sprays for pain, and again, making sure that the parents are using antimicrobial cleaning to clean surfaces so that everyone in the family does not get this. Influenza, we have types A or B. A is usually more prevalent. Um, it's the most common months for influenza in the US are October through May, so usually fall, winter, and springtime. Transmission wise, it's transmitted by droplets, so through coughing, sneezing, contact with contaminated objects. So the person, if admitted, is usually on contact droplet precautions. Usually, the client will have a self-limiting type symptoms of fever, chills, headache, coughing, sneezing, muscle aches, malaise, possibly conjunctivitis as well. Typically diagnosed by a rapid flu screen or a respiratory panel screening. This could trigger croup in younger children or turn into pneumonia. We need to educate the child on proper hand washing and the parents on disinfection of surfaces, encouraging fluids, and then, of course, getting the annual flu vaccine to prevent it. Two treatments for influenza are Tamiflu and Relenza. So these are antiviral medications that can help with the symptoms of the flu. The only thing about them is that they must be given within 48 hours of the onset of symptoms. Mononucleosis, also called mono, and also called the kissing disease because it's transmitted through saliva. It doesn't have to be transmitted through kissing. It can also be transmitted through things like sharing drinks or chapstick. It is a viral infection caused by the Epstein-Barr virus. It's most common among teenagers, but it can affect anyone of any age. So one of the problems with this is that it can be very contagious because it can be excreted for months after infection, the virus that is. Some of the symptoms are fever, sore throat, malaise, pharyngitis, enlarged cervical lymph nodes. And again, these symptoms usually last 1 to 4 weeks. In some instances, it can lead to long-term chronic fatigue syndrome. It can also cause splenomegaly and hepatomegaly. And because of this, if the spleen is enlarged, we do need to limit contact sports for about 6 to 8 weeks to avoid any injury to the spleen. Respiratory syncytial virus, or RSV. We already kind of talked about this when we talked about bronchiolitis, because bronchiolitis is usually caused by RSV. But again, this is a common cold for adults and older children, and then usually called bronchiolitis for infants, or those that have chronic conditions like chronic lung disease or were born prematurely or some sort of chronic heart disease. It's transmitted with contact with saliva and nasal secretions. Signs and symptoms: cough, runny nose, and fever for older children. For younger children, this is where we're talking more about bronchiolitis. So it could turn into respiratory distress, breathing quickly, wheezing, severe coughing, retractions, accessory muscle use, nasal flaring, poor air exchange. Hospitalization could be needed for infants with bronchiolitis or pneumonia. At home, they can use a cool mist humidifier. Inpatient, we may have them on oxygen. We may have them on IV hydration because they may be breathing so quickly that it's not safe for them to eat. Doing frequent respiratory assessments, like every 2 to 3 hours, and frequent suctioning with these little nasal suctioning devices that's pictured here on the bottom, or through deep suctioning, which is the picture on the top. So frequently, these babies and young children cannot clear their own airway because they simply just don't know how to blow their nose yet. So we have to do it for them. There is the Synagis medication that we can give to premature infants or those who are at high risk who qualify for it to help prevent RSV in those populations. Like I talked about before, it's very, very expensive, and the child has to qualify through different qualifiers to get the medication paid for through their insurance. Roseola is caused by human herpes virus type 6. It's transmitted through the saliva of persons who actively have the disease or who are carrying the virus who have had it before. So this disease is extremely common. 75% of adults are carrying it. Most people have had it by the time they are 4 years old. The hallmark of this disease is that there's a high fever for about 3 to 7 days. Um, High fever, meaning it's not just like 100 degrees Fahrenheit, could be 103 or even higher. Since the fever is so high, it may trigger febrile seizures in some patients that are more prone to it. We'll talk more about this in the neurological module, but febrile seizures are not like regular epileptic seizures. They don't cause any long-term neurological effects or damage. They are literally just caused by the very high fever, and then the patient may never have them again. After the fever breaks or goes down after the 3 to 7 days, the patient has this papular pink or red rash that emerges. Many patients, though, can be asymptomatic, possibly just have the fever, possibly just have the rash, and no other symptoms. Besides the fact that the fever is very high, it's usually a benign and very self-limiting illness that's just taken care of at home. Again, we can make sure that the parents are keeping the child adequately hydrated, giving them antipyretics for their high fever and pain, things like cool washcloths to the head, basically just home care for this one. Rubella, also called German measles or even called 3-day measles. So rubella is obviously one of the infections on the MMR vaccine. So this infection is caused by the rubella virus, transmitted through respiratory droplets or contact with these droplets. It can also be found in the blood, urine, or stool. The child is usually asymptomatic or just has a very mild fever and a rash that lasts about 3 days. The rash usually appears on the child's face first and then spreads downward throughout their body. Where we really start to worry about this is if a pregnant woman becomes infected with it. So we want to have children immunized against this to protect pregnant women in the community. Because if a pregnant woman does get rubella during their pregnancy, the infant could be born with congenital rubella syndrome, which would mean that they could have congenital heart defects, congenital cataracts, deafness, mental retardation, even miscarriage and fetal death. So not a huge problem for actual children, but we want to worry about it most with pregnant women. Rubiola or measles, also referred to as 7-day measles. This one is a virus caused by the actual measles virus, transmitted through airborne transmission. Symptoms of this: runny nose, cough, fever, conjunctivitis, malaise, small red spots in the mouth with a bluish white center called Koplik spots. So this is the bottom picture. It's sort of hard to see the bluish white center on this PowerPoint. And then on the body, a brownish red macular rash that starts at the hairline and then spreads downward throughout the body. We want to keep the child isolated for 5 days after the rash appears to prevent spread to others. One thing we worry about with measles is this could develop into measles encephalitis, which can be very severe and can cause brain damage that the child would need ventilator support. Could cause pneumonia, seizures, deafness, um, mental retardation, and even death. So we have had outbreaks of this more recently that you may have heard about at places like Disneyland or where there's huge gatherings of people. Since people are choosing not to immunize in certain situations or for whatever reasons, we've seen outbreaks of some of these diseases that we had not really seen in a while. But we can manage fever with acetaminophen or ibuprofen, um, give soft bland foods, keeping the child hydrated, using a humidifier and things like that for more mild cases. Varicella zoster, or commonly known as chickenpox. So varicella usually causes chickenpox in children. More rarely, it can cause shingles. It is transmitted from fluid from the vesicles of the infected person, also from secretions from their nose, mouth, and eyes, and also it's airborne from coughing and sneezing. So if they are admitted, it would be contact and airborne isolation. They are contagious 1 day before the rash appears, while the rash is spreading, and until all of the vesicles that they have completely crusted over. The key finding with this rash is that the lesions are usually in different stages of formation and healing. So meaning at first they may be more of like a flat vesicle, or not even be a vesicle, maybe no fluid in it at all. Then it turns into a vesicle that is secreting fluid, and then it's crusted over or scabbed over. So all over the child's body, there's different stages. Usually first appears on the trunk and face. The main symptom with this one also is just severe, very severe itching with the rash. Also fever, headache, and malaise. So some interventions we can do is try to prevent the child from damaging their skin and getting a secondary infection by making sure we cut their nails short. If it's a very small child, I could be applying things like gloves or mittens to reduce the scratching. Um, Applying calamine lotion. Calamine lotion is just that pink over-the-counter lotion, if you've seen that before. And other things like oatmeal baths. There is a vaccine now for varicella, so many children are no longer getting this. Conjunctivitis. So conjunctivitis is just commonly called pink eye, usually caused by a virus or a bacteria for what we're talking about. But you can also have allergic conjunctivitis, which is just when your eyes are red because of an allergy. But for what we're talking about, the transmission is contact with discharge from the infected eye or touching a contaminated surface. With viral conjunctivitis, the conjunctiva is usually red or pink. The eye may be swollen. It's usually only affecting one eye, and the discharge is usually just watery. With bacterial conjunctivitis, which is sort of what we think of as conjunctivitis, the conjunctiva is usually very pink or red. It could be swollen, a lot of purulent drainage, and the eye may be actually crusted shut in the morning from all of the drainage. The eye can also be very itchy or even painful. So treatment for this one is antibacterial eye drops, could also be eye ointment. We want to avoid contact with the dropper to the eye so we don't contaminate it, and making sure we're squeezing the drops into the conjunctival sac and not right onto the eyeball. We also want to try to make sure the child isn't touching their eyes. We want to make sure they're washing their hands frequently and that we're sanitizing surfaces because this can spread very, very easily. pertussis is also known as whooping cough. So it's caused by the Bordetella pertussis bacteria. It's transmitted by oral and nasal secretions. So this disease is most dangerous to young infants. It can result in severe respiratory distress and dehydration, which could need them to be hospitalized. So this is why we recommend basically all pregnant mothers get the pertussis vaccine. Sometimes it's even recommended to all family members or who are going to be around the new baby to prevent them from getting this. There's a characteristic whoop sound after the child has a coughing fit. So it's called sort of a coughing fit because the child is coughing sort of severely and excessively for a long period of time. So it's not like they just have one little cough and then they stop. They're literally coughing for, a minute, or it doesn't have to be a specific period of time, but it's a lot of coughing. And then at the very end, they make this sort of whoop sound, sort of like thinking about if they're taking in a really deep breath and sort of struggling. There should be an audio bite on this slide for you to hear an actual child with whooping cough. They can also have other symptoms beside the cough, like general cold symptoms, runny nose, fever, and the coughing can be so intense that it actually causes vomiting and cyanosis. So basically, they're coughing for such a long period of time that they're not able to take very good breaths. Strep throat, also sometimes called scarlet fever. This is caused by group A beta hemolytic streptococcus. So basically an extremely sore throat. This can affect all ages and adults, but it's more common in children that are over 2 years of age, so especially school-age children. It's transmitted by droplet spread and direct contact with any respiratory secretions. So a very severe sore throat, headache, they could have a stomach ache. It's sometimes called scarlet fever because some patients will also have a rash. So they can have a rash on their groin, axilla, neck folds, their trunk area, and they could have enlarged lymph nodes. After this rash fades, if they have it, it can actually start peeling of the skin on their fingers and toes, like this top picture. They can also have pallor around their mouth, and their tongue can be swollen and look sort of like a strawberry. So we call it strawberry tongue, like this picture of this tongue on the slide. Other more severe complications with strep throat can be glomerulonephritis, so kidney problems, and rheumatic fever, which we'll talk more about in the cardiovascular lecture. So usually they're prescribed penicillin or amoxicillin or a similar medication. We can also recommend things like gargling salt water, which is hard for children to do because it's not very fun, or other things like anesthetic mouth sprays to help numb their throat, throat lozenges, and things like that. Anything that has went in their mouth, we want to tell them to replace because it has been contaminated. So things like replacing their toothbrush after they get over the illness. Impetigo is a bacterial skin infection that's caused by Staphylococcus. So this skin infection is a reddish macular rash that then becomes vesicular, like in this picture. This rash erupts easily and leaves these moist skin erosions, which can secrete fluid. So the secretions can be sort of these honey-colored crusts. It doesn't have to be on the face, like in this photo. It can really be anywhere. It spreads peripherally and by direct contact. It can be very itchy. So we want to recommend that they are washing hands frequently and try to cover the rash if possible to prevent spread to others. Like on this picture on the face, it's going to be pretty much impossible to cover it. But if it was on like an arm or a leg or the trunk, you could more easily cover it. It's treated with an antibiotic ointment. For severe cases, there could be IV or oral antibiotics. So we wouldn't normally expect a fever because this is usually just a skin infection. However, if the child does develop a fever, we would want them to be seen by a provider because they may need oral or parenteral antibiotics at this point. Tinea infections. So these tinea infections are basically different fungal infections on different areas of the body. So tinea capitis, capitis meaning head, is ringworm of the scalp. So this is that top left picture. So this causes these scaly lesions that are usually circular shaped with alopecia, meaning that hair is going to fall out in those areas. Interventions for this are going to be things like different shampoos, and making sure that the patient isn't sharing hats or brushes or anything that touches their head with others to prevent spread. Tinea corporis, corporis meaning body, is ringworm of the body. So this top right picture on the slide. So sort of what we sometimes think of when we think about tinea infections is ringworm. It makes these round or oval scaly patches on different areas of the body. This one's also usually treated with a topical antifungal. Tinea curis is sometimes called jock itch. So this is basically a fungal infection that can be on the inside part of the thigh, even on the scrotum of males. It's very itchy. There can be round, scaly patches with this also, or sometimes it sort of looks like this bottom left picture, like a big red area that's very, very itchy. Again, for this, topical antifungals. Tinea pedis, also just called athlete's foot, pedis meaning foot. So the fungus grows in moist areas of the skin on the person's foot, called athlete's foot because if you think about people's feet sweating in their shoes and in their socks, and it's staying really moist in there for a long period of time. Sometimes there's a white exudate, but almost always there's peeling areas that may bleed very easily. Sometimes it can just look like very dry skin. It's usually very, very itchy. So interventions for this, more topical antifungals, alternating shoes, and changing socks. So if a person does have sweaty feet for whatever reason, making sure that they are changing their socks and putting on different shoes also. With some of these infections, if they do become severe or more widespread, there are oral medications that can be prescribed. And for some of these, we may want to cover the infection to prevent spread, especially things like the ringworm of the body. Pediculosis capitis is head lice. So head lice causes intense scalp itching and sometimes even like tickling or irritation of the head, small red bumps on the scalp. An adult louse is approximately the size of a sesame seed. So this top picture looks a little blurry, but that sort of brown spot the size of a seed is an adult louse. Nits look like little white specks that are firmly adhered on the hair shaft near the base, so near the scalp. So this is that bottom picture. So they're very, very small, so you can't necessarily see what it looks like. It just looks like this little white speck. You can't just brush the nits off with like a regular brush. You can't just take a shower and get them to come off. You have to remove them with a nit comb, which is a comb with the teeth on the comb are extremely, extremely close together. One of the treatments is 1% permethrin shampoo. This shampoo is contraindicated in children with ragweed allergies. So we want to caution using this in children with ragweed allergies and with asthma. We want to wash all clothing and bedding in hot water with detergent. So anything that you can wash, put in the washing machine with hot water. Anything that's too big to be washed or is unable to be washed because of whatever fabric it is needs to be placed in a trash bag for 14 days to allow the lice to die. Dermatitis and eczema. So, contact dermatitis is where the skin becomes inflamed and irritated after it comes into contact with some sort of irritant or chemical. So, diaper dermatitis is a type of dermatitis um, in children or adults. We just don't usually call it diaper dermatitis, where they get a bright red rash and ulcerations that extend gradually. So, this is that top left picture. So we want to change the child's soiled diaper promptly. And we can also apply a skin barrier. So like zinc oxide, even hydrocortisone ointment. Zinc oxide is the one that's very, very white that you can also use as a sunscreen. There's also a prescription type skin barrier called Ilex, which you don't wipe off all the way. But with any of these, say if the child just pees in their diaper, we don't want to wipe off the skin barrier cream with each diaper change. If they do poop, you can wipe it all off because the cream is probably going to have poop on it. But if they just urinate, we can sort of leave that intact because if we're putting on sort of a thick layer of it, the urine isn't going to touch the skin, which is what we want. So we want to prevent urine and stool from coming in contact with the skin because this is going to cause the diaper dermatitis. Sometimes with certain kids, it can be if they eat certain foods, like more acidic foods, like if they eat pineapple, for example, is more irritating to the skin when they poop it out. Seborrheic dermatitis is also known as cradle cap. So this is the top right picture. A lot of times it has an unknown etiology, so we don't know exactly what causes it in certain babies, but it's a self-limiting condition where they just have these scaly crusts on their scalp that eventually goes away. So it's really just more annoying than anything. But to try to get the cradle cap off, we want to gently scrub the scalp to remove the scales. So you can use some type of oil to soften it, like coconut oil or whatever type of oil, olive oil, to soften the crust, and then gently use a fine tooth comb to remove them. But we don't want to like be scraping the skin or anything like that. We're just very gently removing it. We also want to shampoo daily to try to prevent it from coming back. And that's going to be using like a gentle baby shampoo. Another type of dermatitis is atopic dermatitis, or more commonly just called eczema. So eczema sometimes has an unknown etiology also. It can sometimes be associated with children that also have asthma or food allergies. So it can be associated with other allergies, irritants, so things like fragrance scented detergents or lotions or perfumes, warm, dry environments like Arizona. And there may actually be some sort of genetic component because sometimes it may run in families. The rash can look a little bit different on different people, and it can be in different areas depending on the person. On this bottom picture, it's on a baby's face, which is common in babies, but it can really be anywhere on the person's body. We want to educate the person to keep the skin hydrated. So again, using lotion or some sort of body oil, but again, they want to use one that doesn't have any irritants in it. So like fragrance-free, dye-free. Avoiding irritants or things that they are known to be allergic to. So sometimes we'll do allergy testing to see if they are allergic to certain foods or certain irritants that they come into contact with daily. We can also recommend tepid baths. Um, so that tepid meaning like the water just isn't excessively hot. The excessively hot water, although it may feel good, can dry out the skin too much, and we want to keep it moisturized. Commonly prescribed topical steroids like hydrocortisone, or there's a bunch of different types of topical steroids. They may be prescribed antihistamines because the rash is generally very itchy, so to try to cut down on the itchiness. There's also immunomodulators that can be prescribed for severe cases. Acne is the most common skin condition in adolescents. It's usually self-limiting, meaning that it will usually go away over time. However, there is a wide range of severity from very minor acne to very severe. Very severe, especially, can cause significant self-image and self-esteem problems, especially in adolescence. It does involve the hair follicle and sebaceous gland complex, and hormonal fluctuations can cause flare-ups of acne. Lesions, which are called comedones, are either open, and those we typically call blackheads, or closed, which we call whiteheads. So comedones is just sort of like a fancy word for pimple. Treatment for this, they could be prescribed oral or topical antibiotics, so something like doxycycline is common. Also, other topical comedolytic agents that can be either prescribed or over the counter, things such as benzoyl peroxide and salicylic acid washes and creams. And then also there are other medications such as Accutane, which could be prescribed as well. Cellulitis is an infection and inflammation from some sort of break in the skin, usually caused by Staph aureus, MRSA, or even Hib. It can be other things also, but these are just the most common ones. So on the skin, there's going to be redness, swelling, warmth, tenderness, and sometimes red streaking, as you can see in these photos. The red streaking is actually where it's going along the lymphatic vessel. So to find out what sort of bacteria is causing this, they're usually going to culture the wound if there's an open wound or the skin. We can also do a blood culture to see if there is a systemic infection, especially if they do have this streaking. Also a CBC and white blood cell count. They're going to be at least on oral antibiotics, if not IV antibiotics, if it has gone into their blood. One thing we can do to see if this is getting worse is to use a skin marker to draw around the red areas to assess if it is spreading. So like on these pictures, simply just taking a skin marker or even a Sharpie and drawing around where the redness is. So then when you come back and assess the patient later, whether it be a couple hours later or 12 hours later, you can see if it has spread beyond the lines that you made. They can also have other um, systemic symptoms such as a fever, if they have gone septic, chills, and generally just not feeling very well. Insect bites and stings. So especially in Arizona, we can be bit or stung by a lot of different things: bees, wasps, hornets, yellow jackets, fire ants, scorpions, snakes. So in mild reactions, mild local reactions, a small red itchy wheal that is warm to the touch. Um, so if someone is not allergic to bees, for example, they could just have a very small red itchy wheal, could also be painful, that's warm to the touch. Systemic reaction, where if the person is possibly allergic or just has a heightened reaction to one of these things: edema, worsening pain, even nausea and vomiting, confusion, respiratory problems, all the way to anaphylaxis. So if the thing that stung them or bit them has a stinger, we want to remove the stinger, cleanse the area. You can apply a cool compress, give them topical or oral antihistamines. If they are allergic or having a severe reaction, just like with food allergies, we can use an EpiPen or an EpiPen Junior. So the EpiPen Junior is for children that are less than 30 kilograms, and then EpiPen is for everyone else that is larger than 30 kilograms. If we're giving an EpiPen, some of the EpiPens come with ones that you can demo with or that the person can sort of practice with that doesn't have any medication or an actual needle in it. So sometimes there's like a separate one that comes with a real EpiPen and then one that they can practice with also. But we can educate them that there's no visible needle before the injection. So when they take it out of the package, sort of on this orange end in the picture, there's not an actual needle sticking out. This is one where the needle is sort of retracted inside the syringe body, and it's not going to come out until we actually sort of stab them in the thigh with it. So we're going to inject it into the thigh or educate them that they're going to inject it into their own or into their person that they know that's having a reaction's thigh. No specific area, really just anywhere in the thigh muscle. Holding it in there for 10 to 15 seconds for the medication to be released. Then when they sort of remove the EpiPen from the person's leg, the needle retracts back up into the body. So there's never any chance of a needle stick for this one, or it's at least greatly reduced. This one you can massage the area after the injection. And we want to recommend that they seek medical help after the injection. So even if they're like, great, I didn't have an allergic reaction because I used my EpiPen, it is epinephrine. So it can cause some cardiovascular problems, and they should be checked out by the provider after using it. Burns. So when we're talking about burns, there's different degrees of burns, and they're very similar to the different degrees of pressure ulcers. So a first degree burn is just superficial damage to the epidermis. So the best example of this is like a sunburn or getting burned by something like a curling iron or on a hot oven. So just the top layer, just the epidermis is damaged and nothing below. Second degree burn is where we're going down a little bit deeper into the dermis. So here the top layer of the epidermis is basically destroyed and we're down into the dermis, just like a second degree pressure ulcer. Third degree, we can call a full thickness burn, where the burn's damaging all the way down into the subcutaneous tissue. So it can damage hair follicles, sweat glands, and nerve endings. Fourth degree burn is damage all the way down to the muscle or bone. So going through all the layers, destroying everything and all the way so we can see the person's muscle or their bone. So when we're talking about burns, we can use the rule of nines. So the rule of nines basically estimates body surface area burned. So this is something that's going to be used possibly in the field, like for EMTs or in an ER. We're trying to basically estimate how severe is someone's burn and how much of their body does it cover. So you do not need to memorize these percentages, and sometimes if you look at different texts, they're slightly different. So you don't need to memorize it. Really what you need to know for the tests is just how to add them together, which I am very confident that you can do. So say if a child burns both of their arms, each arm is 9%, so we add those together, we would estimate with the rule of nines that they have burned 18% of their body. First and second degree burns that are covering less than 10% of the body are just considered minor burns. When we start involving other areas, I don't want to say more important, but they kind of are more important, things like our face, our hands, our feet, and our genitalia, those are just automatically considered major burns. So if you have a child that has burned, say, both of their hands, although on here there's no percentage listed, but just thinking about our hands, they're a very small portion of our body. Even though they are a very small portion of our body, since our hands are obviously so important to us to live, it's automatically considered a major burn and recommended that they go to a burn center, even though it's a very small area. Burns that are involving over 30% of the body are generally considered major burns. And children usually require hospitalization if greater than 10% of their total BSA is burned. So this means that usually they're going to be transferred to a burn center, which here in the Valley is usually Valley-Wise. So just in general burn care. So if we have superficial burns, you can soak them or run them under cold water, but we don't want to apply ice to burns. So ice can just further damage the tissue, so we don't want to apply that. Cool water may feel nice, and that is totally fine, but just no ice. You can also apply a cool compress, so like a washcloth with cool water in it, but again, no ice. Again, if it's superficial, so something like a sunburn or a low-key burn from a curling iron, applying lotion frequently, keeping it hydrated. If there is a blister, we don't want to pop it. Yes, a provider may pop the blister if necessary, but popping it is going to introduce infection possibly. So in general, we do not want to do that. We can apply antibiotic ointment in a nonstick dressing. We want to make sure that the dressing is nonstick, so obviously it doesn't stick to the burn, which is going to cause further tissue damage. We can treat the pain if they are in pain from their burn. For severe burns, say like someone that is in a house fire, a car fire, we want to apply 100% oxygen immediately and help maintain and assess their airway. We want to assess for shock from dehydration. Burns can quickly dehydrate a person, so we're going to begin fluid replacement and prepare for transfer to a burn center. So if they have severe burns, they're usually going to be transferred to a burn center. If they are in some sort of fire situation, like a house fire, especially where there is smoke, we want to monitor for airway obstruction. This can be sort of delayed 24 to 48 hours after the actual incident. So even if they seem fine right after the incident, at least respiratory wise, we want to make sure we're still doing frequent monitoring of their respiratory status because airway obstruction can come about 24 to 48 hours later.